Dear Alpa friends, today is Global PSC Day, and I want to thank all the people that again this year, for the second time, took time to explain PSC and some unmet needs of PSC patients worldwide. But my words today are especially addressed to all the liver patients that are fighting against rare diseases. Nothing about rare diseases is simple, not the diagnosis, not the daily care, and especially not the long term. A patient with a rare disease faces two battles, one being the illness itself, and the other living in a world where so few people understand what you are up against. So stay aware, spread awareness, take action. A disease may be rare, but hope should not be. Together, we are stronger.
Hi, everybody. I'd like to welcome all of you to our second annual Global PSC Awareness Day. I'm hoping that today will really give everybody a lot of information from all over the world about the unmet needs for PSC patients. And hopefully in the years to come, those unmet needs won't exist anymore. Have a wonderful day, a wonderful year, and remember that we are all here to help everybody. And there's lots of hope for a lot of different things that will happen in the future for PSC patients.
Hello, my name is Henriette Jetting, a hepatologist from Hvidovre University Hospital in Copenhagen, Denmark. And first, I'd like to congratulate you on this with this day focusing on a very important topic, PSC disease, and thank you for the opportunity to share a few words about the challenges and quality of life in PSC. So what may challenge quality of life living with PSC? Symptoms. Most patients do not actually have symptoms or only have mild symptoms. However, a lot of patients carry a lot of worries with them. So the features of PSC, it's a chronic disease and with an unpredictable disease course and a potential increased risk of malignancy. As mentioned, most patients do not have symptoms even if they have developed cirrhosis, whereas a proportion do experience symptoms either sometimes or constantly, and they may be physical or emotional. For the physical symptoms, the major ones are pain, discomfort, or pain or discomfort in the upper abdomen. They can experience itching and jaundice or fatigue, the feeling of batteries running down very quickly. And patients with simultaneous inflammatory bowel disease also experience diarrhea, pain, stomach pain, and other symptoms. So what do we keep an eye on to follow up on PSC? Well, with laboratory tests, we check whether there are signals of worsening or maybe development of cirrhosis. And we use imaging, predominantly MRI or ultrasound, to check the status of the PSC changes, to look for fibrosis and potential malignancy. And with ultrasound, we do an annual screen for gallbladder polyps. Also, endoscopy is used. When diagnosis of PSC is made, we screen for inflammatory bowel disease. And if it's present, an annual colonoscopy is advised. So in the light of these conditions, it's not rocket science to understand that PSC may affect quality of life. So what is quality of life? That's different for each unique person. But for all of us, these factors are important. The mental health, the feeling of safety and comfort, self-esteem, social factors to be accepted and to be part of a community is important for the mental health. And also physical factors, of course, the feeling of a well-functioning body and absence from disease symptoms are important factors. So I'll share with you 4 examples illustrating the experience of PSC in different patients. So Erik is 28 years old. He's newly diagnosed with PSC and has no symptoms at all. But on his second visit to the outpatient clinic, he was very worried and said, "We had planned to buy a house and have kids. Now we don't want to run that risk. When will I suddenly be a transplant candidate?" Whereas Camilla, 41 years old, who was diagnosed with PSC during pregnancy 7 years ago, she struggles with quite severe fatigue, but manages to work 30 hours a week. She has quite a lot of itch, which is kept at a tolerable level with cholestyramine treatment. She is happy and doesn't worry. Henrik is 61 years old. He's had PSC for over a decade, but 4 years ago, imaging showed development of cirrhosis, which really shocked him. And since then, every day has been heavy from worrying, even though he feels perfectly fine physically and works more than full-time and has a rich family life. The last example is Michael, who is 43 years old. He's been suffering from PSC for 14 years, quite progressive course. He's got upper right quadrant pain and itching, but he doesn't worry. So this illustrates that the quality of life is not directly associated with physical symptoms of the disease. So how can we try to measure the quality of life in PSC? A lot of models and questionnaires have been developed and suggested, but they show very heterogeneous results, which is, of course, due to cultural factors, age, socioeconomic factors, how much help can you get from your community or your social system, and also disease-specific factors and features play a role. In this study published in 2018, the authors reviewed different quality of life assessment methods for PSC. So they included generic questionnaires addressing any kind of disease, it could be used for any kind of disease, and also disease-specific questionnaires and symptom-specific questionnaires, mainly itch and pain. So they included 37 studies, which used 36 different patient-recorded outcome measures, PROMs, one of them pediatric. The questionnaires covered patients from the whole spectrum, from very early disease to transplant patients. And the conclusions from the authors were that there's a wide variety of tests and none have been sufficiently validated, but they pointed out that the PSC Pro seems promising. And the PSC Pro was developed and published also in 2018 and focuses on disease-specific features of PSC. It can be self-administered in both paper and electronic form, and it takes up to 15 minutes to complete. This PSC Pro was validated in a quite thorough process in England, including a lot of patients and doctors and other healthcare workers. And the main comments from the patients were that PSC Pro better covers the quality of life issues in PSC than the SF36 does, which is a very well-known and used quality of life measure. To end with, I'm thinking forward about how can we get on with understanding quality of life issues better in PSC, and by that improve the quality of care and quality of life. So I think it's very important to keep exchanging knowledge, that patients report to their doctor when experiencing new symptoms or changes in their condition, and to share their thoughts and worries. Because seen from the doctor's point of view, the challenge is to offer sufficient and correct observation and advice without overwhelming the patient with worry and without making the disease fill too much of the life, because basically it's all a question about living life. And I hope that future investigations and optimization will help patients to live life better. Thank you.
Happy Global PSC Awareness Day. My name is Dr. Kirsti Mom. I'm a transplanted pathologist and the medical director for autoimmune liver diseases at California Pacific Medical Center in San Francisco, California. I'm also a member of the Diversity, Equity, and Inclusion Working Group of PSC Partners Seeking a Cure. First, I would like to thank PSC Partners, the European Liver Patients Association, and all the other patient advocacy groups for the work you do every day in teaching people about this rare liver condition, PSC, supporting patients and caregivers, and your hard work every day, trying to close the gap in the unmet needs of PSC, hence the topic of focus at this year's Global PSC Awareness Day. I will be covering one of the unmet needs, which is identifying and mitigating health inequalities in PSC. Data from the US, the American Association for the Study of Cancer, shows that certain part of the population tends to be affected significantly by cancer in the US. This special or unique patient population actually include patients that are of racial and ethnic minority groups, individuals of different ancestry, individuals with low socioeconomic status, individuals with disability, individuals who have limited means in insurance coverage, for example, in patients living in rural area, or gay, lesbian, and transgender community, immigrant patients, patients that are actually trying to seek asylum, and also adolescents as well as the elderly patients tend to be affected unfairly in terms of cancer outcome. Their data shows that, for example, African Americans have a higher risk of dying from prostate cancer or breast cancer. As you can see, the poor outcomes are significantly higher and many types of cancers in this special patient population. When we're looking at healthcare disparities in patients with autoimmune liver diseases, including PSC, there seems to be an inherited additional challenge for many reasons, as we all know. These diseases are rare and difficult to diagnose. We haven't well understood the cause and identified all at-risk patient population. There's again a limited understanding of the natural history especially in diverse patient cohorts, including patients from North America and patients living in other continents, such as South America, Africa, or Asia. There is a limited or no approved medical therapies, for example, in PSC, and access, as a result, access to specialized health centers and clinical trials is very important. So these additional factors actually pose an additional challenge in living with PSC. When we look at who's really at risk of PSC, it's not unusual to hear from some of our minority patients that they've been told by other providers that PSC affect people that are Caucasian and they shouldn't be affected by the disease, as a result, leading to delay in diagnosis of PSC and even putting them at risk of poor outcomes. As what you see here is a cross-sectional study that was done by Dr. Goldberg from the North America Autoimmune Liver Disease Consortium group that looked at the proportion of Black patients that are Black patients with PSC that are actually managed in these 13 large liver centers all over North America. Really opened up our eyes. It showed that the proportion of Black patients with PSC, as you can see here, range from, for example, 0.7% of their PSC cohort and at University of Calgary up to 25.7% of their PSC patient cohort at Henry Ford Health Center. And when that was compared with the proportion of Blacks living in that particular metropolitan area, based on data from the US Census Bureau, it seems to be parallel. So the proportion of patients with PSC seen at their centers tend to be parallel to the proportion of Blacks actually living in that particular metropolitan area. This data is not necessarily proving or showing that PSC is as common in Blacks compared to Caucasians, but it really shows that it's not a rare condition in Blacks. Blacks are also affected by PSC, and we need more data, similar data showing this. When we look at clinical outcomes of minority patients affected by autoimmune liver diseases, the data is actually very rare. I've cited one study here published in 2021, which used the United Network for Organ Sharing data. This is including liver transplant recipient in the US from the year 1988 to 2019. As you can see on this graph, it showed that African Americans with autoimmune liver diseases were more likely to be removed from the wait list due to death or clinical deterioration compared to Caucasian. However, once they are listed, once they receive liver transplant, this study showed that there was no difference in post-transplant graft survival between the two. So there tends to be a higher rate of not making it to transplant, being removed from the wait list for days or other clinical problems in patients that are Black. This is looking at everyone with autoimmune liver diseases. There was one study that evaluated outcomes, clinical outcomes of minority patients with PSC. This used patients that were waiting for liver transplant in the US from the year 2005 to 2017. This cohort had 4,046 patients with PSC that were listed for liver transplant between these years. And the proportion here is showing about 82% were whites, 12% was African American, 4% was Hispanic, and 2% were Asian. This paper showed that compared to non-Hispanic whites, Hispanics had a significantly lower probability of receiving liver transplant. with the hazard ratio of 0.73. So a lower chance of probability of receiving liver transplant after being listed for Hispanics. This paper also shows that African Americans had a significantly higher risk of post-liver transplant days. This is African Americans with PSC had a significantly higher risk of post-liver transplant deaths compared to the non-Hispanic whites with significantly higher standard hazard risk here. When we compared the proportion of patients that are actually listed for liver transplant between those 2 years in the proportion of each racial group from the US Census, for example, in year 2021, about 18.5% of the US population was Hispanic, but here we have about 4% of Hispanics that are actually listed for liver transplant in the US. So there seems to be a disconnect for sure. So what are some of the barriers that are actually affecting the care? So there was a good review published in Hepatology recently in 2021, which stated that we're actually not immune. There are racial and ethnic disparities in autoimmune liver diseases, and really highlighted that there are multifacets of socioeconomic determinants of health disparities and broke it down in 4 categories. These factors can include biological factors, for example, that could include genetic and hereditary predisposition. There are economical factors, which includes income, wealth, access to insurance, access to care, social factors, including language and cultural barriers. Those are huge, and health behaviors, our habits, diet, exercise, and whether or not patients are exposed to tobacco or alcohol, other things that could affect their health, and physical environment, for example, exposure to different toxins. And when we looked at if there are any studies actually studying how this socioeconomic deterrence of health can affect patients with PBC, autoimmune hepatitis, or PSC, as you can see on this table summarized, there is a huge lack of data. So for example, in PSC, we can say that there isn't any study looking at how these factors can actually affect patients with PSC. So we have a lot of work to be done. As we think about studying how some of this socioeconomic determinants of health can affect patients with autoimmune liver diseases, including PSC, it's really important that we also put equal effort parallelly in how we can also promote health equity. As indicated on this diagram that I borrowed from the National Organization for Rare Disorders website. As you can see on this image, for example, these 3 people of different height are trying to watch a baseball game behind this fence. Some are too short, some are just almost there, and some are very tall. If we are giving them the same height stool to stand and watch the game, we are not getting everyone above the fence to watch the game. So the shorter guy will need more help. This person has just the right height, and this person here did not need the help, but he did get one. So we didn't do our job. We didn't get everyone above the fence to watch the game. So what we should do is actually support the shorter person with a taller stool to stand on so that he can watch the game, and give this average height person just the right amount to also be able to watch the game. And this tall person did not need the help, so he can actually stand and watch the game himself. At the end, we got everyone above the fence to watch the games. This is equity. And what is really important and even more powerful is if we can get rid of the fence, none of them will need this additional support. So the concept of equity is powerful. It is actually a continuous commitment to meeting people where they are so that optimal health can be achieved for all, as seen in the diagram here in the middle. So in summary, we know that PSC affects patients with various ethnic and socioeconomic background. We've seen that the limited data that I presented suggests that underrepresented patients with PSC seem to have poor clinical outcomes. However, there is a large gap in our understanding of the impact of these various barriers and how they could affect health in patients with PSC. The next step is really promoting health equity for PSC, or MPSC should be a global effort. We need to put more effort in studying the natural history of PSC by sampling patients across the globe. For example, we have no data from Africa, for example, and probably limited data from Asia and South America. So these patients are also affected by PSC, and we need to put our effort globally in understanding how it's impacting their life. We need to work on identifying the barriers affecting health in PSC, and also parallel to that, implementing changes that could actually improve or mitigate these barriers so that we can improve care for everyone affected by PSC. Thank you again for allowing me to be part of this very special day. Happy Global PSC Awareness Day, everyone. Thank you.
My name is Gideon Hirschfield, and I'm a liver doctor who works in Toronto. I run a large autoimmune liver disease program, and I'm really pleased to be talking to you on Global PSC Awareness Day, 29th of October 2022. PSC is a very important disease for our patients, and it's a very important disease for myself, as I spend a lot of time looking after people living with this very tricky disease. As you know, PSC is a large bile duct disease, largely, and that means that there's inflammation and scarring and blockage in the bile ducts. For this reason, one of the symptoms that patients complain of particularly is itch. What I'd like to focus today on my short Global PSC Awareness Day talk is therefore itch and how that impacts on the quality of life of our patients living with PSC. So bile has to leave the liver, and bile contains a variety of substances which are noxious. When there's bile duct blockage, which is what happens in PSC, and or inflammation and infection, again, which happens in PSC, patients can notice this because they can itch. The itch of PSC is slightly different to the itch of other liver diseases because it can fluctuate, because bile flow can fluctuate, and blockage can come and go, and blockage can also be relieved. We don't know exactly which of the components of the bile cause the itch, but we understand that the nerves in the small nerves in the skin are activated by substances, and this can cause a quite distressing itch, often feeling like ants under your skin in your hands and feet, often worse at night. Now, itch is a symptom that patients don't always report to their clinicians. It can be a symptom with some stigma because people worry about being considered that the itch is due to an infection, but really it's a very tedious, unpleasant, and tiring symptom for our patients. If you're itching all night, it's hard to work all day. If you itch, you'll have fatigue. If you itch, you'll be at your wit's end. It's really important that we tell our patients to speak up about their itch, because whilst it's an unmet need to understand the science, there are treatments that we can use to help our patients. So when I see someone with PSC who's itchy, then my job is to make sure I understand the nature of the blockage, whether it's new, whether anything on the MRI is concerning, and whether or not there's any intervention that's needed either by ERCP or by medicines. Usually I treat the itch through medicines, and the medicines that I use have a variety of different functions. Cholestyramine is a bile acid sequestrant. Rifampin is a drug that makes bile acid metabolism go quicker. Bezafibrate is a drug that shuttles bile acids in a different way in the liver. And other drugs such as gabapentin change the nerve fiber function and reduces the itch burden. At the same time, we also look to clinical trials. And pleasingly, there are a number of drugs in development which affect bile acid recirculation as well as bile acid sensing in the nerves, which may interest our patients around the world and may prove to be opportunities to really treat itch in PSC better. So there's a lot of effort going on around PSC generally and including symptom management, and that includes the itch of PSC. Now, itch is often seen in PSC as a sign of impactful disease, and it's usual when someone is itch that their alkaline phosphatase is elevated in PSC. This usually means that they have disease that will be more impactful and may be on a journey quicker to liver transplantation, but this is not always the case. Therefore, every patient needs to be evaluated individually, and that includes their blood tests, their FibroScan, their MRI, and their ultrasound. So to summarize, I really want patients to speak up, tell their clinicians about their symptoms, itch being one of them, and to realize that there are a number of options for investigation and treatment that can improve the quality of life, and that living with itch can be very difficult, but we have a number of approaches that can make a real impact. I hope collectively this short video contributes to learning about PSC, that PSC is a disease that needs greater awareness amongst all stakeholders, and that Global PSC Awareness Day recognizes the huge efforts being undertaken by patients, clinicians, regulators, industry to make a real impact for our patients to develop new treatments for quantity and quality of life in PSC. And I hope everyone enjoys all of the short videos that they hear today on Global PSC Awareness Day.
So thank you for giving me the opportunity to speak for Global PSC Awareness Day. And I'm going to discuss the unmet need of clinical trials and medical therapies for PSC. So we know that PSC is an immune-mediated, rare, chronic liver disease characterized by inflammation and fibrosis and destruction of the bile ducts, both within the liver and outside, that progresses over time. An IBD coexists in the majority of patients diagnosed before, at the time of, or even after liver transplantation. And I think we need to be mindful of this unique combination of the liver, the bile ducts, and the bowel, and the gut-liver axis when considering medical therapies and also designing clinical trials. The natural history of PSC is variable, and hepatic biochemistry and symptoms will typically fluctuate. IBD disease behavior doesn't necessarily mirror that of liver disease, and liver disease progression is slow, with a prolonged preclinical and actually subclinical phase with a low event rate over time. Fibrosis and cirrhosis occur due to persisting inflammation and cholestatic processes, and to date, we don't have any medical treatment known to slow disease progression. And liver transplantation is the only curative treatment option and a lead indication in certain European countries. The pathogenesis of PSC is complicated, and gaps in our understanding have really hindered the selection of potential therapies. We know that both environmental and genetic susceptibility are important, and disease is driven through factors related to the gut microbiota, to toxic effects of the bile due to altered bile composition, due to autoimmunity from T cells, macrophages, and neutrophils, all contributing to inflammation, fibrosis, and carcinogenesis. Mechanistic targets from clinical trials have therefore centered around these pathogenic mechanisms related to targeting the bile acids, the microbiota, and also the immune modulators and fibrosis. Treatments targeting bile acids and the gut microbiota in phase 2 studies have an impact on the alkaline phosphatase, which is a surrogate marker of cholestasis. Despite the rationale for immune modulators, however, a positive impact on ALP is rarely seen. And actually, more importantly, the impact on biliary strictures and progression to end-stage liver disease is yet to be fully assessed and is being assessed currently in phase 3 trials. So normalization of the alkaline phosphatase is indeed a surrogate endpoint to improve survival in PSC, but we know that ALP naturally fluctuates in PSC, and it can actually fall in 30% of patients irrespective of therapy and in association also with cirrhosis. So we're in desperate need of better markers for disease progression in these trials. The International PSC Study Group have looked at combined endpoints, including transient elastography, histological endpoints in fibrosis, bilirubin, and more recently ELF and also MRI. And this is very much the direction of travel for phase 3 trials. So I want to touch on some of the key targets of interest shown in phase 2 and going on to phase 3 clinical trials, especially with those that target bile acids and also the microbiome. So 24-nor-ursodeoxycholic acid, it's a side chain shortened derivative of ursodeoxycholic acid, and it bypasses the full enterohepatic circulation. And this leads to the bile salts being reabsorbed by the cholangiocytes and rendering the bile less toxic to the epithelial structures because they're all bicarbonate rich. It's got anti-proliferative, anti-fibrotic, and also anti-inflammatory effects. And in a multi-center European-wide phase 2 double-blind RCT, 159 patients were randomized to either placebo or nor-ursodeoxycholic acid with 3 separate doses, and the trial reached its primary endpoint, and that is a decline of alkaline phosphatase at 12 weeks that was dose-dependent, and it was well tolerated with no adverse safety effects. And this has now led to a 24-month phase 3 trial looking to recruit 300 patients across 83 different centers in Europe. And these patients have large duct PSC with compensated liver disease and persistently elevated alkaline phosphatase, with a co-primary outcome, and that's non-progression in liver fibrosis stage and a partially normalized alkaline phosphatase, and patient-reported outcomes being seen as important secondary measures. The farnesoid X receptor is a nuclear hormone receptor, and when it's activated, it inhibits bile acid synthesis, increases bile export, and decreases reuptake, and it can be used as a bile acid therapy. Whilst the FXR agonist, obeticholic acid, actually increase pruritus and also increase low-density lipid cholesterol in phase 2 trials, non-steroidal FXR agonist, chyloflexor, has increased potency and selectivity to reduce these side effects. And in a phase 2 randomized control trial of 52 patients who were randomized 2 to 2 to 1 with 2 doses of chyloflexor versus placebo over 2 weeks, the primary outcome was safety, and it reached this primary outcome. In addition, alkaline phosphatase fell particularly highly in the 100 milligram arm, and it didn't induce pruritus like the other FXR agonists. And this has led to a global multi-center phase 3 study to assess fibrosis, which has recently completed recruitment of 400 patients over 96 weeks. And the target population being non-cirrhotic PSC, irrespective of alkaline phosphatase, and the primary outcome, and again, being looking at the fibrosis stage at 96 weeks of treatment. And I guess we eagerly await some of the results of this trial. Then there's bile acid therapy with the PPAR agonists. We know that PPAR can occur in 3 isoforms, the alpha, the gamma, and also the delta, and these are expressed widely throughout the body. And these regulate bile acid homeostasis, as well as lipid and glucose metabolism and also inflammation. And they have anti-cholestatic as well as anti-inflammatory effects. Bezafibrate, we know, activates all PPAR subtypes and equimolar concentrations. And in PBC, we know that actually clinical trial data and real-world experience has shown that it reduces alkaline phosphatase and also is an anti-itch therapy. And in a multi-center open label study across France and Spain, reporting on 20 patients with persistently elevated alkaline phosphatase despite treatment with ursodeoxycholic acid for at least 1 year, 40% of patients had a reduction in their alkaline phosphatase, and 10% of patients had complete normalization of ALP after 3 months of treatment in patients with PSC. Furthermore, a multi-center phase 2 platform trial in cholestatic liver disease looked specifically at itch, the FITCH trial. 44 of these patients had PSC, and there was a significant reduction in both the morning and the evening pruritus based on the visual analog scale, and also a parallel reduction of alkaline phosphatase, which is really quite exciting results. And this has led the way to a 24-month phase 3 study combining ursodeoxycholic acid and either bezafibrate or placebo, which is currently recruiting in France. The primary outcome, again, being a composite endpoint of a reduction in alkaline phosphatase, a normal bilirubin, and no increase in the fibrotic LMS. So in terms of the last bile acid therapy, this is an engineered FGF19 analog, which regulates bile acid homeostasis. And this again was assessed in a double-blind placebo phase 2 trial of 62 patients over 12 weeks. And actually it didn't reach its primary endpoint of the ALP reducing, but what it did show is a reduction in the transaminases, in the bile acids, and also a reduction in the non-invasive markers of fibrosis. And I think that has opened our eyes to the fact that there are more important things sometimes than the alkaline phosphatase alone, and it highlights the importance of other surrogate markers in these clinical trials. Now, I just want to mention very briefly a few of the phase 2 trials that are recruiting in PSC targeting the immune system, fibrosis, and the microbiome. Specifically, CCL24, a chemotactic cytokine that stimulates collagen synthesis. It's widely expressed and activated in immune cells and also in activated myofibroblasts. And treatment with this monoclonal antibody reduces inflammation and fibrotic pathways in a number of preclinical models of systemic inflammatory diseases. And the phase 2 randomized control trial is currently recruited in PSC patients over 12 weeks, with the primary co-endpoint being a mean change of alkaline phosphatase in the ELF score, and you get 5 intravenous infusions. The next is an antifibrotic oral small molecule that inhibits the alpha-4 beta-6 integrin, promoting tissue fibrogenesis and also tumorigenesis. And again, this is a phase 2A randomized control test looking at safety and tolerability of this oral inhibitor in PSC over a 12-week period that's actively recruiting. Mesenchymal stromal cells are non-hemopoietic cells that influence and exhibit immunomodulatory effects, and they've been trialed in many different diseases. And in this single-arm, multi-stage phase 2 trial, they assess a single infusion of mesenchymal stromal cells, the primary outcome being a change in alkaline phosphatase, looking both at patients with PSC and a high ALP, and also in patients with autoimmune hepatitis. Moving on to the gut microbiome, we know that antibiotics over time have been used to manipulate the gut microbiome, and vancomycin is more of a gut-selective antibiotic, and it's been shown in children to actually really improve cholestasis and was associated with immunomodulatory effects. In adults, there have been a number of small studies showing an improvement in alkaline phosphatase and also in Mayo risk score, and now there's been a phase 3 study that's underway to evaluate the potential benefits of vancomycin in adults with PSC. Lastly, looking at fecal microbiota transplantation. Again, this has been shown in many disease states to actually restore the microbiome. And this is an open label safety trial in 10 non-cirrhotic PSC patients with inflammatory bowel disease in remission on minimal therapy. And it was given via colonoscopy, and a single inoculation was safe and improved alkaline phosphatase in 7 out of 9 patients, and also increased bacterial diversity. And again, this has led to some funding of some recent trials, including the Fargo trial that's been done in the UK, looking at FMT in adult patients with PSC over 48 weeks. So I think you'll agree it's really an exciting time for PSC. In the clinical trials website, there are 106 different trials listed, targeting a variety of different mechanisms. And I think ultimately we are searching for drugs not that just improve cholestasis, but also improve the long-term outcomes in these patients, leading to preventing the progression of disease, preventing decompensation, and the holy grail really of kind of regression of disease and preventing transplantation and death. But along the way, we're learning lots about patient populations, we're learning lots about endpoints to use, even if these trials don't reach their primary outcome. And importantly, we're starting to understand the outcomes that are important to the patients. So in conclusion, I think there's a lot of hope for the future for PS clinical trials. We're moving out of our silos, and I think we need to learn from other diseases in clinical trial design and surrogate endpoints. We're moving from phase 2 to phase 3 and 4 clinical trials of those areas of interest, and away from alkaline phosphatase to also looking at other fibrosis markers. We have an increased interest, not just in secondary outcomes, but now in primary endpoints for patient-reported outcomes, looking at itch and also fatigue. And lastly, I think we have to think about combinations of therapy, which are likely to be additive in this disease, and it may not be a one-size-fits-all. And I think we need to educate everybody on the role of clinical trials and access to clinical trials for all of our patient PSC population. And lastly, I just want to say thank you very much for your attention, and Thank you for listening.
My name is Svein Oskar Frigstad. I'm a medical doctor and head of Department of Gastroenterology in Vestre Viken Hospital Trust, Bærum Hospital, just outside of Oslo in Norway. My interest is fatigue, and especially then in inflammatory diseases, inflammatory bowel diseases and chronic liver diseases. To the latter, I want to congratulate you very much today on the PSC Day of 2022 and try to give you some insight in what fatigue is and what it means for you as patients. So what then is fatigue? We define it as a feeling of tiredness, reduced energy levels, reduced muscle strength, and cognitive impairment. That's a heavy definition sometimes to understand. To describe it a little bit more simple, it's a tiredness that is not relieved by sleep. We don't have any objective tests that we can do in our clinical practice to figure out who is suffering from fatigue and who is not. We use questionnaires. They are mostly used in research, but also in clinical practice or for the normal evaluation. Most importantly is to address it. The patient needs to tell about it, be willing to expose him or herself, and the doctors need to address it during a consultation to really figure out what's going on. We also believe that a multidimensional understanding is needed. Fatigue is a physical fatigue, but it's also a mental fatigue affecting cognitive function, concentration, sleep, and energy levels. So how common then is fatigue in chronic disease? We know that in the background population, you and me and everybody can have transient fatigue at certain points in life. We can have periods where we don't sleep well or other stress factors affecting us. That is not really a chronic fatigue. A chronic fatigue is a persistent and pervasive fatigue that stands over time, more than 6 months. In the background population, actually 10 to 20% of the population will report fatigue also at any point in time. But if you have a chronic disease, then it's much higher. And in chronic liver diseases, we know that fatigue is reported by up to 70% of patients. And in cancer, actually even higher numbers. And what does it mean then for the quality of life? That's really why we have to address it, because we know that persistent fatigue impairs quality of life. We know that many patients actually think this is one of the most bothersome complaints that they do have, maybe even more than other symptoms of the disease. We also know quite a bit about who gets fatigue. We know that more people of higher age, more women, people with chronic disease, higher burden of some symptoms, patients with chronic pain or reduced quality of sleep, all of these factors affect fatigue negatively and is more common. Smoking is a negative factor often associated with more fatigue in smokers than in non-smokers, and certain medications used may influence fatigue. We can think about, for example, steroids, prednisolone that many of patients need to use. We know that patients using those medications report fatigue more commonly. We also know that duration of disease matters, how long you have had the disease. If you have very active disease, lots of symptoms, and long-standing inflammation, it's more common to report fatigue. But also sometimes the degree of symptoms may decrease over time or reported to decrease. And that is because many patients actually get used to having fatigue over time. And the question maybe then most often I get from patients is fatigue the same as depression or anxiety or other psychological factors? It is not, but it's explained by some overlap of symptoms that we actually do see an association between fatigue and some psychological symptoms, especially depressive symptoms and anxiety. So there is an association, but fatigue and depression are certainly completely different conditions. So what then is the role of deficiencies? We know that vitamin deficiencies, anemia and iron deficiency may produce fatigue and certainly is associated with fatigue in patients with chronic disease. In certain conditions, we see that vitamin D deficiency also has this association, especially in neurological disease and in some cancers, but also in liver disease. And then the ultimate question, what can we do? That question probably many of you have discussed with your doctors and maybe even your family, and try to figure out different things to do. My approach would be that a systematic way of addressing the different aspects of fatigue is the way to go. First of all, the underlying disease needs to be treated properly. You need to go through all aspects of it with your doctor. Is there any chronic low-grade inflammation not treated? Are there any medications that I shouldn't be using or should be using? Can I stop something that gives side effects? And be sure that every aspect is treated and that there is no other chronic coexisting disease. We call that comorbidities in our language, but coexisting disease. Many patients with autoimmune diseases have more than one condition, and they may interact, and it's then important if you talk with a specialist to see the whole picture of what's going on in each and every one of you. Then it's important to rule out deficiencies. Especially iron deficiency is important to correct. And we do believe that vitamin D deficiency and vitamin B thiamine deficiency is important to correct. And some studies even suggest that fatigue may improve in supplementation. It's important to address to yourself and with healthcare personnel, if you need help, to address smoking habits, use of alcohol, use of sedatives, and maybe sleeping pills. All of these factors, it's very helpful to try to reduce use of alcohol, reduce use of sleeping pills and other medications that may affect fatigue negatively. It's important to check for infections. Maybe there is a chronic infection that is a little bit silent and may produce symptoms with fatigue over time, and especially that's important to address in immunosuppressed patients. And many of you are probably using immunosuppressive medications for different conditions, and then it's important to check if that is really necessary or if some silent infection is giving you any kind of trouble. Psychological comorbidities need to be checked. I told you earlier that there is an association between depressive symptoms and anxiety symptoms and fatigue. It doesn't mean that there is a manifest depression or anxiety disorder, but it means that it's important to treat these conditions to address any psychological problems if you want your fatigue to get better. Some ways of doing this is to have very clear activity plans, do something regularly or every day, try to even make a diary of what you manage to do every day and be a little bit happy when maybe the next day is better than the day before. Low intensity physical activity is also recommended, and it's actually well proven in studies that low intensity physical activity, for example, walking half an hour most of the days of the week, will improve fatigue in chronic disease. Some other treatments have a little bit of evidence, but the quality of evidence is not convincing. For example, electroacupuncture, something called solution-focused therapy, which is some kind of psychotherapy, and also use of biologicals. They may all reduce the stress of fatigue, but the recommendation is not strong for any of those treatments. But they may be discussed as they may benefit some of you. If there is no psychological comorbidity at all, we do not recommend psychotherapy. So I hope some of this have been helpful for you. The main point is to have a multidimensional view of what fatigue is, to not be afraid of addressing this and discussing all the problems with your doctor. and remember some of the advice that I give you. And good luck and have a good PSC day. Thank you.
ELPA was honored to welcome all the speakers today because only by working together, creating networks, and generating and disseminating reliable knowledge, we can make fundamental changes to patients' lives. ELPA is hugely proud of seeing today so many people from all over around the world fighting together. Remember, together we are stronger.